in the post-op period, there's a few weeks of uncertainty as to pathology. But in that time, again, optimizing patient care so that if they need further treatment, they can receive it is so critical. So how can we work in that time, to get the best outcome for, the patient functionally speaking?
Yeah, so we work very closely with our patients post-op. It's been really interesting because we went from many years ago, we were doing open thoracotomies and then VATS and now robotics, and the incisions are getting smaller and smaller, and the complications and the symptoms post are much, less. I mean, there's less pain. They're in the hospital shorter, so they've done really, really well. And then it's that waiting time until they start their next step in the process. So, but they usually do very well after surgery, and talking to them what to expect and then the next steps.
Yeah, I have to say that as a physician post-op, when I examine these patients, I'm like, you had surgery and there's like a tiny hole, like half of your lung came out. Yeah. So sometimes it's unbelievable that the surgeon actually completed the job, but the CAT scans seem to suggest that they did. So
they usually do quite well.
But kidding aside, so major improvements everywhere, robotic surgery, etc. Pathology now post-op, it's such an exciting time to look at that report and see PAT CR, but we don't always achieve that. In your view, Jay, where does this stand as to who are the patients who will need more treatment? Where's the research that's needed to kind of address those questions?
Yeah, so right now the consensus is if you get past CR, you don't need anything, and if you have non-PCR, then you need something. Whether that something is effective is very controversial, but I think this is too simplistic. I think, because when you look at the PCR data from Checkmate 816, and the PD-L1 negative cohorts, even though they achieve PCR, they drop down to the non-PCR patients over time. And so, and then the ctDNA positive patients that have PCR, it's not clear what happens to those patients. So PCR group is a heterogeneous population, but no doubt that if you achieve PCR, that's where the most favorable patients are. But what I'm saying is that there are still higher risk relapse patients that are in the PCR group. The flip side is we're going to need to further develop the concept of percent residual viable tumor. There's grading different levels of non-PCR. And we've seen the data from Checkmate 816 and then from Keynote 671 where you see cutoffs of greater than 60 or 80% residual viable tumor. They do really poorly. Are these patients that'll really never respond to IO no matter how much IO and how much you escalate with combination therapies? And should we be thinking about different strategies? And then we need to couple the path regression with ctDNA. The first correlation with degree of path regression with ctDNA status post-resection was from LCMC3 with neoadjuvant 2 cycles of atezo and what happened to those patients. And then Aegean also showed that similar data, and their data was ctDNA clearance pre-treatment and post-treatment chemo-IO, but just before surgery. And again, you need to clear both, achieve PCR and get ctDNA clearance to be in the best group. Any other combination falls behind. So yes, the distinction right now is PCR, non-PCR, but future trials and exploratory analyses are going to need to refine what PCR really means and the varying levels of percent residual viable tumor.
Absolutely, such excellent comments. We need better biomarkers to enrich patients for certain treatments, and we need better treatments for certain cohorts of patients, and this is where clinical trials, clinical research, will bring, further value. We're just so excited in this field to see all these new ADCs, but also really like space-age technology, like tailor-made neoantigen vaccines for the individual patient coming into this space. But let's talk about the patient who might have had a PAT CR. Maybe the conversation is not to give adjuvant treatment and the patient is just getting surveilled. Maybe I can ask you, Mary, first, and then I'll ask Momen a follow-up question as to what's the space like? The surveillance, the scanxiety. How can we minimize?
Yeah, when you go on to surveillance, it's every 3 months, and then every 6 months. We do ctDNA also as we're kind of moving forward. And there is a lot of anxiety around that. Patients are concerned about recurrence, and so we try to work with how to decrease your risk of recurrence as much as possible, particularly with smoking cessation. But then also to tell our patients, if it does come back, we do have treatment options. And some people were like, well, what would you do if you did it? And I'm like, things have changed so much, and it's so exciting about how much research has gone in and how patients are doing so much better because of the knowledge that we have from the research, that I said, if it does come back, we will have a plan. And whatever, it's hard to know what that plan would be because 6 months down the road it might change. But we're in a really good space right now. Not only do we have great options front line, but second line and third line, our patients are doing well.
Yeah, absolutely. So well said. So many exciting options. But hopefully the cancer will not recur.
Hopefully it doesn't come back. But
So,
if it does,
Momen, maybe I can ask you, and this is a question that kind of puzzles me. So these patients, we follow them for a number of years. Afterwards, do they need some lifelong surveillance strategy? And didn't we just learn a couple of weeks ago that CAT scans cause cancer? How do you address that question?
Unfortunately, there's no robust data to support any sort of strategy. I think there's consensus. There's NCCN guidelines and CHEST guidelines. Majority of guidelines suggest that after surgical resection that maybe you do every 6 months for a couple of years, and then you do annual. Some say there's no end in sight, and some guidelines say you gotta stop at 79 or 80. So really, it's hard to know what's right. We don't have enough data. I think our strategy has been to continue sort of annual surveillance. It's akin to the lung cancer screening, and if you've had cancer, probably, again, after 80 becomes controversial. I think it becomes an individualized decision based on your patient's factor, preference, risk, etc.
Great.
Yeah, and to make a point about that, the NCCN guidelines does say low-dose CT after 5 years, but it isn't particularly, it's not exactly a screening CT, and there's sometimes confusion around that. They may not meet screening eligibility criteria with their smoking. Maybe they never smoked before. But we do follow it up with a low-dose CT as a diagnostic, but not a screening CT, so they can continue into the program as a lung cancer survivor.
Fantastic. Certainly survivorship programs are kind of coming alive, because our patients need, long-term support. That's truly a fantastic problem. We didn't have that a couple of years ago in the lung cancer space, but we have more and more patients who do well and require that attention.
We also have a survivorship clinic that we refer them to, too, which I think probably all of you do.
Exactly. We just opened one about a year ago.